In today's video, we're going over 6 keys to slap tear physical therapy rehabilitation. What's going on, guys? This is Dan Pope and Kevin Coughlin. We're both physical therapists at Champion Physical Therapy and Performance. And boy, Kevin, we have a really good one for you today.
We do. Yep. I think last week we finished up with going over slap tears. Now we get the keys to treatment. So I think the keys to treatment will be a great episode.
I'm quite excited about it. I'm gonna let the listeners know about a little summary about what we're gonna go over today. What do you think, Kevin?
I think that's a good way to kick it off.
All right, let's kick it on off. So we have 6 keys, and the first key is whether or not that patient is going to be a good candidate for physical therapy. The second one is to avoid provocative maneuvers. Ooh, that one sounds exciting. Number 3, restore pain-free range of motion. Number 4, strengthen the cuff and scapular muscles. Number 5, get specific. And number 6, return to sport. What do you think, Kevin?
Let's dive in.
Let's dive it in. One thing I will say about slap pathology that I think is a little bit different than other pathology, and it's kind of funny to me, and I think it's just kind of how the research has kind of gone over the course of time, is that slaps are even more common than rotator cuff tears, right, in the average person. But we see them more in athletes and treat them more in athletes, particularly in overhead athletes, okay? And one of the themes of treating slap tears is that you actually treat it very similarly, right, to other sorts of pathology like rotator cuff related pain. It's just that most of the research is going to be on throwers, particularly baseball and pitchers. So a little slant of what we're going to be doing today is talking about how to rehab baseball players. Did you know we're going to do that today, Kevin?
I did. I actually did my homework and looked through your beautifully prepared slides here. So
Nice.
Ready to talk a little baseball.
Yeah, good stuff. And the first study, and we're going to be referenced this a lot, is going to be a 2022 paper by the Journal of Shoulder and Elbow Surgery. Phenomenal journal. It's called Return to Play Following Non-Surgical Management of Superior Labrum Anterior to Posterior Tears, a Systematic Review. Let's get into this. First key, are they a candidate for physical therapy? And we talked a lot in the past about slap pathology, particularly instability. And when instability is a player, oftentimes, especially if it's a traumatic instability event, we're thinking about surgery sometimes as a first course of care, right? For slap pathology, that's not necessarily the case. And there's some research showing this. And it's also something when I talk to other smart physical therapists like Mike Reinold and also some of the surgeons I follow, slap repairs are not as popular as they once were. So it seems like more and more we're seeing more slap tears being treated conservatively. It's almost like if you're like a baseball pitcher, we know you have one, right? It doesn't necessarily mean that you can't get back to throwing. Sometimes it's incidental, might not even be the structure that's creating your pain. So we almost always trial conservative care first. The only instance, and we'll talk about this in a second, where this might be a little bit different is if there is a traumatic event and there is a lot of instability associated with the slap tear. If that's the case, sometimes we're going to look at doing a primary surgery first as opposed to conservative care. But for the large majority of folks, you start these guys off with physical therapy, with rehabilitation. To go along with today's video, I have a free evidence-based cheat sheet on slap tears. I'll get you up to date on all the literature on slap tears in under 10 minutes. We go over anatomy, prevalence, and risk factors for getting a slap tear. We go over the mechanisms of injury as well as a clinical presentation. We cover differential diagnosis as well as diagnosis. What are the best treatments for slap tears? Is surgery effective for a slap tear? And is physical therapy better than surgery for slap tears? Lastly, what are the return to sport rates for slap tears, both conservatively, so with physical therapy, versus getting a surgery, so either getting a biceps tenodesis or slap repair? It's a 5-page PDF. It's 100% free. I'll leave a link in the description. Go ahead and click on that and download it and get back to this video. Pretty wild. What do you think about that there, Kevin?
Yeah, I think that's always a good first step. And I thought those statistics were interesting. I think we talked about this on the previous slap episode that we had. But with that Steinmetz article that we were just talking about, it was something like 50% of athletes returned to play in total. But the ones who were able to successfully complete their rehab program, that number shot up like you had up there to 78% or 72%. So it shows that the rehab can really be successful if you can complete the rehab program. So definitely worth trying initially. And it doesn't seem time dependent. Like if you wait a little longer to see if you can avoid a slap surgery, it doesn't seem that you're going to get worse outcomes than if you just get the surgery right away. And as you had just said, we hear from Mike and other people in this area all the time that for baseball players, for overhead athletes, you probably want to try to avoid that slap repair. So might as well try that non-op rehab first. We know it's probably you have a good shot at being successful if you can get through the rehab, and if not, it's not a rush necessarily.
Yeah, for sure. You stole my thunder 100% there, Kevin. It's okay. It's okay. And I think that is an important part because this study was interesting. We talked about this in the other episode, but it was kind of hilarious because I think I just read through the abstract at first, and it said that the return to sport rates were like 50%. I was like, oh, that's not really that great. But then they said if you complete a rehab, they were 78%, right? And I was like, oh, that's actually much better. That's more than 3 out of 4 people are going to be able to return to sport. And then I think the more important parameter for a lot of athletes is, are you able to return to sport at the same rate? And that was pretty decent. That was 72%. And that's good. What I will say is that it probably depends a lot on the sport. Unfortunately, some of those baseball pitchers probably not going to be able to return back at those same rates. But if you're like an Olympic lifter or something along those lines, then your chances are probably quite a bit higher. All right. So in the same study, the average return to play was at 5.2 to 5.7 months. And that ranged between 3 and 6 months plus. And this was interesting to me because that's a pretty long period of time, right? So if you end up with a slap tear and you're trying to rehab conservatively, probably do need to give this quite a bit of time, right? And I don't know if they kind of crunched these numbers in the study. I'm assuming maybe they did because they're trying to figure out factors that would predict a failure of non-op. And obviously one of which is if you didn't finish your rehab. But if some of those folks were finishing their rehab at 3 months and returning back, right, I would kind of figure that if you don't spend enough time on this, it might not return at the same rate, right? Although that didn't seem to be the case. But I think the takeaway is that it takes time, right? This is not like a ankle sprain where you're getting back 1.5 days, whatever it is, average return to sport after injury. This is something that really does take time, right? In that study, I thought this was other pretty good number, and I'm stealing it from the last presentation, but the average number of visits that these folks had was somewhere between 8 and 28, right? And then the factors that predicted failure of non-op rehab, and I highlighted the ones that I think are important. So basically, if you play an overhead sport, your likelihood of getting back is a little lower, which is a bit sad because for the most part, these are the folks we care about the most with slap tears generally, right? So if you're an average person or if you're competing in a sport that doesn't have overhead activities as part of what you do, you're probably going to be more likely to have success. But the more you're into these overhead activities, you usually have a little less success. The second one was traumatic injury. We talked about that a little earlier, why that might be. So if you have a traumatic injury and you maybe have some instability associated with that, maybe that's one of the reasons why these folks are not getting back. The other one was concomitant cuff tears, which kind of makes sense, right? You had a worse injury. So if now you're getting cuff injury along with the slap tear, maybe now that's going to be a little bit worse. If you have, a bad enough rotator cuff tear acutely, you probably should get that surgically repaired anyway, right? One study also showed pitching as a risk factor for not having success with conservative rehab, and that's a little bit unfortunate too. So I do think that it's important to have expectations for the athlete that comes through the door. Essentially, the more they want to get back to an overhead sport, the more they want to get back to pitching if they have concomitant pathology. All these things are going to mess up the rehab process a little bit. And the last thing I will say, and you can check out our last episode if you want more about this, surgical patients did fairly well too. So if you have a patient that's not doing well with conservative care, the surgery seems to do pretty well as well. Kaboom. What do you think there, Kevin?
Yeah, good stuff. I think a couple things pop into my head there. One, just on the visit count. I think one thing I see a lot of kind of PTs talking about on social media is trying to reduce visit count as much as possible. And, it's almost like a sign of a good clinician is you got someone better in 2 visits. But I think a lot of these issues, like a non-op slap tear rehab, you want to probably see the person a little bit longer than you think. So that range was pretty large, but average visit number was 20 visits. I'm sure a lot goes into that, like how you're doing your rehab. Are you writing them a good program they're doing remotely, or is this someone that, needs to see you in person? So I think one thing is just don't worry about extended visits if you find it necessary. I don't think we need to fight for the lowest visit count all the time. I thought that was interesting.
Yeah, I
Um,
agree with you.
yeah, I
I
think the
don't
other
think.
thing. Oh,
Go
go
ahead.
ahead. I was just gonna say, I think the other thing that is interesting there is looking at who's completing the rehab and stuff. Is maybe some of these folks can get back a little bit earlier. We had said that like about that 5 month mark, but I know these studies. It's hard to tease this stuff out, but maybe it's the folks who are getting back earlier that aren't at their prior level of play. They're returning to sport, but maybe not exactly where they want to be. So that's something to consider too. Is you might need to take the time to actually returning to sport is one thing, but playing at the level that you want to play at, that might take a little more time as well. So I think counseling the patient on that is, let's be patient because you don't want to go back and as a pitcher have 10 miles per hour off your fastball and just letting up home runs, right? You might need that extra time to get back to the prior level. So just thought that was interesting too.
Yeah, and we'll talk a little about the criteria for turn to play. I think for the most part, the folks got back faster. They probably regained their range of motion a little bit faster. They probably had their pain levels go down faster. They're probably able to speed through the program a little bit more quickly. If there was a study, some of the studies had this, some of them didn't. We'll talk about that in a minute. They were like an interval throwing program. Maybe they started it sooner, or maybe they had a shorter program. It's hard to know. You'd have to really go back and dig into each individual study, which I didn't do a ton of. I'll put a link in the show notes if you guys want to check out the study. I don't know if any of the additional studies are open access. A couple of them are, a couple of them aren't. So that's always a problem when you're trying to figure out. We could probably reach out to the authors and they'd probably be pretty good about telling us, but it was hard to access everything. Number two, we're going to avoid or modify provocative maneuvers. And in this study, they actually said they wanted to reduce inflammation. And in some of the papers, they used oral NSAIDs as well as subacromial injections within the rehab in order to reduce inflammation. They didn't do that for every patient in every study. That was just in some of the papers, right? And I'm just going to say what I believe is most important. If you can do a really good job of modifying everyday activities, and later on we'll talk about modifying gym activities, I think you're automatically going to see that patients start to feel quite a bit better. I think that's for two reasons. So for one, I always say this in the clinic. I stole it direct from Mike Reinold. If you have a rock in your shoe and you're walking around and it hurts, if you take some ibuprofen, it feels a little bit better, but you still have that rock in your shoe, right? Keeps on aggravating that area. If you're doing a whole bunch of things that are aggravating the shoulder, the slap tear, one of the big ones being, let's say, throwing in overhead athletes, then yeah, it might stick around and or get worse. So as soon as you start to remove the things that aggravate the area, folks are automatically going to feel a little bit better because they're not kind of like, to steal a kind of a bad analogy of picking the scab, just because we know that exercise is going to be beneficial. So you don't want to stop everything, but they usually start feeling a lot better. Plus, from a psychological perspective, I think it's a lot less frustrating because you're not feeling that shoulder aching all the time, doing all the things that aggravate it. So I think every time that you kind of aggravate an injury you have at the time, it's just frustrating. It's like this little ping of like, it's still there. It sucks. So if you remove a lot of those things, athletes psychologically start feeling a lot better too, right? So the big ones to modify in lifestyle, right? Because a lot of these folks, if you're dealing with a high-low athlete, they feel fine throughout their regular activities. For some folks, that's not the case. So I just ask a lot of questions about what bothers athletes, and then we just try to come up with a few ideas to reduce some of that injury or irritation. And I don't modify anything if they feel fine, right? So if their everyday activities feel great, I don't tell them they need to sleep in a different position or something along those lines. But a lot of folks will have pain sleeping at nighttime. So we'll talk about different sleeping positions. Usually sleeping on your back or sleeping on your side with a pillow underneath your shoulder can be helpful. We may want to reduce overhead lifting or a lot of activities overhead. The way people put on their jackets, shirts, bras may have to be modified. So maybe you put in the painful side first. So you're not reaching kind of behind your body, hand behind the back, right? In order to do these things. And just eliminate some of these lifestyle things that are provocative can be helpful, right? The second big thing is that we should probably modify in our training. And for overhead sports, one of the big things is you're removing a lot of throwing, right? So for throwing sports, let's say that's baseball, softball, maybe that's javelin, we're removing that for a period of time, usually. We also could be removing serving. If you have a tennis player, certain strokes really hurt, you can kind of remove that some, right? Serving for a volleyball player too. We want these athletes to continue training as much as possible. We just want to take away the things that are really provocative. And the other piece is that if you're like a fitness guy like me, strength and fitness, maybe from a weightlifting perspective, we have to dial back or modify the snatch or the bench press, overhead press, or dips. Essentially, you have to ask your athlete questions about what's provocative so we can give them better modifications and or temporarily eliminate these. And I think for the throwing athlete, baseball especially, we do take away throwing quite a bit, right? Do you want to speak on that a little bit, Kevin, just because you work with a lot more throwers?
Yeah, I think when we see throwers with shoulder or elbow issues, unfortunately, taking away throwing is something that we have to do sometimes to get them over the hump. And there's a few reasons for that, but one is that when we get these people into the clinic and we're looking at their overhead range of motion and their strength and their shoulder, is one thing Mike Ronald and I hear Mike Scaduto say all the time at work is throwing makes you tight and it makes you tired. So when pitchers are throwing a lot in season, they might have had a high pitch count a couple of days before, their shoulders really sore. They come into the clinic and they may be missing, 15 or 20 degrees of overhead flexion on their throwing side, which, as you can imagine, would change their pitching mechanics a little bit. And then also when we strength test these folks, and we'll talk about return to sport criteria, but these are things we look at is we'll test their strength and, they may be 15 or 20% weaker on their throwing side. So if you take someone who's that tight overhead and weak because they're tired from throwing, and you continue to have them throw and they have something like a slap tear, it's only going to make them feel worse, right? So if we're on the table and we're arranging their shoulder and we see that reduced motion and it's painful, just those simple tasks hurting means they're not going to feel good throwing. And sometimes the athlete still wants to see, they'll take a couple of days off till their symptoms feel a little bit better. And, if they're not hitting that return to sport criteria, most of the time it seems like they'll go out and try to throw. And when they ramp up intensity, they start to hurt again. So, we just try to educate them on that, this might need maybe 4 to 6 weeks of shutting down. We'll try something like that, depending on the time of season. That takes some nuance too, because it depends what they have coming up and, how important what's coming up is for them. But we'll try to shut them down a little bit. We'll wait for the pain to calm down. We'll let the strength build back up. And then usually with that little bit of time off and rehab exercises, they start to feel a lot better. So without modifying lifestyle, it would be real hard to get them back on the mound quickly.
Yeah. A couple things. You said a lot of really smart stuff there. I think the first of which is that you do a lot of measurements, right? You see how patients are progressing. So we check their range of motion. We'll talk about how to do this in a minute, but you're checking overhead flexion, you're checking external rotation, internal rotation. Are we restoring that range of motion? And a lot of what we do at Champion PT and Performance is that we like to check range of motion in their off season when they're not throwing to see what their baseline is. And we're constantly checking range of motion to see how much they're losing or even gaining sometimes. Gives us an idea of how much stress that shoulder is taking. So we're trying to get that range of motion back to where it was previously. We're also taking measurements of their strength. We're doing this objectively. We're not doing manual muscle tests. Hey, push against me. Oh, that feels strong or that feels weak. We're getting actual numbers on that. We can use that to guide our care. So essentially, when we're talking about that 3 to 6 months return period, maybe those folks are getting back faster. The range of motion improves faster. Strength comes back faster. So we feel better about, let's get back to that interval throwing program. And that's kind of how you can guide your rehab based on that criteria as opposed to like just timelines, right? The other thing I wanted to say is that I stealing a term from Chris Johnson. He uses the word cavalier all the time. And I don't know why, but I just found that I like that word now, although it sounds silly every time I say it. When it comes to, let's say, running, when it comes to weightlifting, if it's kind of a tendinous problem, right, or even the joint related problem, I will try to continue running and training through the injury. And we'll use the pain monitoring model a little bit. And I think for a weightlifter, someone who's in the gym, we're almost always want to continue training. And we probably are okay with pushing through a little bit of pain as long as your symptoms are improving over the course of time. One of the things I learned at Champion is that we tend to shut down athletes more frequently if they're throwers. And I don't know if it's something specific about throwing. Like the forces on the shoulder when you throw are just astronomical, and I imagine that's one of the reasons why. But as opposed to modifying throwing and throwing a little bit less, we tend to just shut them down completely, right? Any thoughts on that, Kevin? Because I know that is a big difference between populations.
It is. I think what popped in my head as you were saying that is I think the injuries that a baseball player can sustain if they keep throwing through pain are more significant from a time loss perspective. So if a pitcher is throwing through, say they're having some shoulder pain and then they start getting some elbow soreness, in baseball pitchers, it's not going to be a like medial epicondylitis, right? It's going to be their Tommy John ligament. So if, what's at risk is missing a whole season, a whole year of rehab, it's a long journey. So I think the injuries they get just seem to be so significant. I mean, time loss injuries. So that's kind of what pops in my head there is like you said, the force is so high. They're throwing with such intensity that they're putting these small little ligaments on such stress that we have to be careful about trying to make a good guess about what their pain generator is, because if it's something like a ligament, or a joint capsule, it just can't take as much stress as your muscles and tendons can when you're in the gym. So it does seem like we have to approach this a little bit differently.
Yeah, I'm blanking on the name of the author, but it was like an editorial on a paper, and it was called "Do Niggles Matter?" And it was in soccer players, so it's not necessarily baseball players, but that's very true. And that's one of the things that I try to educate my patients about. And the paper was basically looking at soccer players with a non-time loss injury. Essentially, they have some sort of injury that hurts, but they can basically still play. And if they play through that injury, are they more likely to get hurt? And the answer is yes. And it was something like 8 times more likely to have either a worse injury of the same area or a new injury, right? And the injury risk was stronger than acute to chronic workload ratio. So we kind of look at acute to chronic workload ratio as one of those gold standards in predicting injury. And training through an injury or pain was actually a better predictor of injury and increase your risk even more so than that. So anytime you're pushing through injury, there is significant risk. And oftentimes you'll have an athlete that's trying to play through their season, and you just have to educate them about that. Be like, look, because they're always asking, can I play? Can I play? Can I play? And it's like, yeah, you can play, but your risk is going to be higher, right?
Mm-hmm.
By how much? Really hard for us to know. But if that game is important enough, we can roll the dice. But it's important they know that they are rolling the dice, because they're looking to us to tell, like, hey, you're going to be fine. But, that's not always the truth, right?
Yeah, I always say that to my patients is, it's a risk reward ratio, and I'll try to do as best I can at understanding the pain problem and educating them on the risk, but it's always their choice at the end of the day. But as long as they know that there is a pretty significant risk of, potentially something happening, then, they can still make the decision at the end of the day.
Step number 3, restore pain-free range of motion. Now, I think this is also a little bit more specific to the baseball player, although I will try to apply this to my weightlifters. It's just that usually with my weightlifters, I don't do this in sequence. It's not like I have to restore range of motion before I start overhead lifting or anything like that. But I think for the baseball player, we are trying to restore range of motion pain-free before we start throwing, right? You get that right there, Kevin?
Yeah, totally nailed it.
Nailed it. I'm going to talk a little bit about total arc because I'm a baseball expert. I'm not, just so you guys know. But this is interesting because, Lenny Macrina always jokes about this. Like every single baseball player that we ever get from a physician will usually say this person has scapular dyskinesia and they have GIRD. So limited internal rotation range of motion. And the whole like scapular dyskinesia stuff, that's an enormous can of worms, right? And the whole GIRD thing is just outdated evidence, right? And what's funny about this paper is that we'll talk about this a little later, is that 5 out of 5 of the studies in this meta-analysis did some sort of posterior capsule stretching. But what we have to make sure is that our patient actually has a deficit. We don't want to start stretching people that are super lax. If you've never heard this before, if you throw, basically as you're growing up and you start throwing, there's bony changes that occur within the shoulder that increase external rotation and limit internal rotation. We know this happens with athletes over the course of time. So if you play enough baseball, you're going to have GIRD. It's just going to happen. It's just that you may have a lot of external rotation. And sometimes we get a patient from a physician that says, GIRD, stretch the posterior capsule. We test internal rotation. Let's say it's 20 degrees. And we test external rotation, and it's like a crazy number. And their total arc is like 220 degrees, and they're extremely mobile. And now we're going to start trying to, tweak that shoulder and try to gain more rotation range of motion when they already have a crazy amount, right? So instead, we look at total arc. So essentially, we're taking the shoulder up to 90 degrees of abduction in the scapular plane, and we're looking at range of motion to external rotation versus range of plus range of motion into internal rotation, right? And we're looking for, let's say, around 170 degrees, right? Would be normal-ish for a baseball player. But we want to see the same on the left side versus the right side. So the non-throwing side, we're looking for some symmetry here, right? And if you notice on the throwing side, you're limited with internal rotation and you have excessive external rotation, and the total arc is actually greater on the throwing side than the non-throwing side, then you might not have a tight athlete at all. You might have a looser athlete on that side, or on the throwing side shoulder. So essentially, if you start, trying to gain more internal rotation range of motion, you're taking a shoulder that's already very lax and potentially trying to make it more lax. I know a lot of folks will argue that if you stretch into end range, you might be strengthening capsules, so on and so forth. I don't know if we have the data to say that's actually true. We tend not to do that. But essentially, in this study, 5 out of 5 of the studies they use for net analysis use some sort of posterior capsule stretching. So that's probably going to be some sort of sleeper stretch, although I didn't go back to see exactly what they did in those studies. I'd like to have you speak a little on this, Kevin, just because you see a lot more baseball players. I know you're testing this all the time.
Yeah, I think you summarized it pretty well, but I think that concept of total arc is really important because we'll have guys that come in often who have seen a physician and say they need to work on, they were told they have GIRD and that was a concern for them. So we'll try to educate them on that when you're young and throwing and your growth plates are open, it's going to twist your arm, retrovert your humerus in a way that gives you more external rotation. So we do compare the total arc side to side. So we'll add up internal and external rotation, and it can give you some insight into what's going on in the shoulder. So sometimes you'll see those numbers, and on their throwing side in the total arc, they might have 200 degrees, and then on their non-throwing side, 180. And as you were saying, that opens up questions about what they're doing from a mobility standpoint. Are they stretching their shoulder? Are they doing like a weighted ball program that's giving them more range of motion? So, you shouldn't see 20 more degrees on the throwing side. Alternatively, you might see 180 degrees on their non-throwing side and 160 on their throwing side. And then we know that there's some limitation in mobility. And instead of going after the capsule and stretching the capsule, the first thing we'll do is work on their mobility. And I know we'll talk about this, their soft tissue mobility. So maybe some of the muscles on the back of the shoulder, like your teres major or your lat, might be a little tight. Some of the external rotators are probably a little beat up. So more from a soft tissue standpoint, and then we'll work on that and remeasure. And with a muscle deficit in range of motion, you're going to see a pretty quick improvement in motion. And, if we can get that person close to like 5 degrees symmetry in their total arc, we're not going to go after the capsule stretching because we just showed them in the clinic that we can restore their motion with soft tissue. It's more something they can do on their own with a lacrosse ball or a foam roller or something like that, and not necessarily the capsule stretching. That may have a place in a kind of rare specific person, but I think if you go through those steps of measuring, maybe doing some type of soft tissue if it's indicated, and then remeasuring. So again, back to measuring, just getting regular numbers, it kind of paints the picture for you, and then you figure out what intervention that person needs.
Yeah, that's a really good point. And I know we mentioned this a lot, but you have to have good surgeons too, because I've seen some surgeons take very lax people and cut the posterior capsule. And I think that's a little unfortunate just because they're already lax and you cut one of their major stabilizing structures in the shoulder because you think GIRD is the driving force. And unfortunately, there are some pretty bad repercussions to a surgery like that, especially in a lax individual. And they're kind of operating off of old data, right? And that's a bit of a shame when that happens, but it does happen. So I think that's why you need to make sure you have good doctors understand this, because even if you start looking through some of the research, especially a paper like this, like it seems like the clear intervention is the posterior capsule. We need to stretch that, stretch that, stretch that. And a lot of this is operating off of older studies. And I don't know what the keys are, right? Maybe we do need to stretch crap out of that posterior capsule, but we don't do any posterior capsule stretching at Champion. And that's kind of pioneered a bit by Mike Reinold and Lenny, just because they've worked with so many baseball players over the course of their career, over a decade in Major League Baseball. But it's pretty amazing how fast you can restore range of motion with soft tissue work. And I know that soft tissue work is kind of under fire right now. It's not that popular. But in a baseball player that's stiff, if you do 15 minutes of soft tissue work, some of the structures, you may completely restore the range of motion extremely quickly. And then you can also give them self-management tools. And we're not attacking those tissues that are probably irritated as much, right? I don't have to crank on internal rotation. That position's already a little bit irritated just from playing that sport. So we think it's kind of a win-win situation. We're not irritating irritated tissues, and we're using something that's relatively benign and something that the athlete can do on their own. And it usually is quite effective. So if you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. All right. So I wanted to talk a little bit about weightlifters. because that's my world, right? And every person that comes through the slap there is not going to be a baseball player, or baseball pitcher, right? I think these rules still do apply for, let's say, a tennis player, right? Or let's say volleyball. Those overhead athletes are going to be treated very, very similarly. I do the same exact thing when I have a tennis player versus a baseball player. Obviously, there's going to be some nuances. We don't have to cut back as much on all their tennis play. It's just the serving, really. And then you can have like a interval serving program at the end of their rehabilitation. We'll talk about these a little bit later. But largely, we're taking away throwing and we're working on restoring range of motion. For a weightlifting population, I'm usually modifying their training. So I'm trying to take away things that are especially provocative, but keep them training in the gym as much as possible. And then I want to restore the range of motion that's really important for that athlete. So the big ones for, let's say, an Olympic weightlifter are going to be flexion, or just overhead range of motion, flexion or abduction, as well as external rotation. So we need external rotation to snatch. We also need external rotation to hold a barbell on our back for powerlifters, and sometimes that gets limited. I think internal rotation is a little bit interesting because for most weightlifting, anything in the gym, you really don't need much internal rotation at all, but you may see a substantial difference from side to side. So you might want to think about trying to restore that. And then extension, which is an odd one. We don't think about extension range of motion very much. It's kind of like a forgotten range of motion in the shoulder. But a lot of my athletes are doing bench press. So essentially, they're going to the bottom position of the bench press, extends the shoulder, push up, same deal. If you're looking at dips, you go into even more extension, or muscle up is even more extreme. So I like to measure that and try to restore that as much as possible, right? So we talked a little bit about this, but our chosen strategy for restoring range of motion is usually soft tissue mobility first, especially in lax individuals. If you have someone that already has a lot of capsular mobility, we tend not to do as much end range stretching. And I know that this is a controversial subject because some folks will argue that if you do end range stretching, you're actually making the capsule stronger per se, potentially, right? Although we can acquire instability as well. So I think that that is, jury's still out on that, right? Because if I strength train at my end ranges, I may actually create more instability within the shoulder joint. We know that happens in pitchers, but those forces are tremendous. We tend to favor soft tissue mobility, but I'll often stretch with my athletes too, especially weightlifters. I don't think that stretching is as provocative for weightlifters as it might be for a lot of throwers. And I love using weighted stretches, right? Or eccentrics. So the research kind of has a variety of ways of calling this, but essentially if you strength train through a full range of motion and you emphasize a stretch at end range, so let's say I'm doing a pull up and I stretch at the very bottom and hang out there for a minute and make sure I'm fully stretching as much as possible and come right back up again. We know that's going to promote range of motion as well as stretching does. And we're building some strength. So that's usually what I like to do. You will actually find a few studies where they do static stretching, they add weight, and that's actually a little bit more effective than regular stretching. And I'll give that to my patients as well. I love thoracic spine extension stretches with a little extra load. So yeah, I am using these interventions with my weightlifters, but for the pitchers, for the baseball players, usually we start with soft tissue, and that's our primary means of gaining more range of motion. We'll do a little bit of dynamic stretch work as well. I think Lenny and Mike do a little bit of stretching to external rotation, but they're not like cranking into end ranges and holding it for prolonged periods. What do you think there, Kevin? I know you do this more than I do.
Yeah, again, I think you summarized that stuff pretty well. I think it takes a good assessment of trying to figure out, is this a capsular restriction or is this a soft tissue restriction? And I think the type of person that we just see at Champion are younger, higher level athletes. And that avatar tends to be a little bit more lax in their joints, but you still want to do a joint play assessment. So, it's kind of easy to just check the different parts of the capsule and just kind of get a feel for how much translation you're getting. Also, like a quick bite and screen is pretty helpful for just seeing how well they move, how much mobility they tend to have. So, that's something that we assess. And then if you're looking at a weightlifter, like you were talking about, that's not a unilateral overhead athlete. So we don't expect them to have the same deficits in internal and external rotation. But that total arc concept is still going to matter. And then we're going to, like you said, we're going to attack that soft tissue first. And we're going to see does that change things for them? Do they have a response to that, or are they still a little bit tight? And if they're a little bit tight, then we take a different intervention. But I think, consistent evaluation and measurement of those things gives you an idea of how to treat.
Yeah, for sure. And I also want to say I'll put a link in the show notes, a link in the description of how to do a joint play assessment. What I will say is that we kind of learned a little bit about how to do this when I was in school, and I kind of stopped doing it just because I didn't feel personally like I was getting a lot of value from it. But if you work in a lax population, this is something valuable to learn, and you'll build that skill over the course of time. So I'll leave a link in the show notes. I do have a video about anterior instability, which is what the majority of baseball players are probably going to have. And I'll show you how to assess it. And I think the big takeaway is that you have to assess a lot of shoulders to figure out what loose feels like and what stiff feels like. But if you assess enough and then you actually feel someone that's lax, like, okay, this person is lax within the capsule. So there are kind of objective ways to measure it, but I think largely it's subjective. You're just doing the mobilization. You're trying to figure out how much motion they have. So any tips on that, Kevin?
Yeah, one thing I just wanted to say that I tell our students often is if you have someone coming in with a upper extremity or cervical spine like pain problem, just check the joint mobility on all of them, and not because it's related. If it's a clear cervical spine thing, it's probably coming from the C spine, but it gives you more reps. So, once you learn how to check joint play, just check it on everyone. Cause like you just said, if you don't know what loose feels like, you got to get a bigger database in your head. So that's like, if we're looking at someone's knee, I do a Lockman's on like a ton of people just so I can try to get a bigger database on when I actually feel something that feels different. So I think that's a good little clinical pearl, is just get more reps in. Like the patient doesn't know what you're doing, and you can do it really quickly. And then you'll learn what a really loose shoulder feels like, or conversely, a really stiff shoulder feels like. And it helps you make better decisions.
Yeah. You got to be careful. I've done this sometimes I do the same thing with Lockmans, and you've done enough. You can kind of feel like what's stiff, what's loose. Every once in a while I'm feeling a knee and I'll feel like the contralateral side, the side that's not injured. I'm like, whoa, that's a lot of motion. I got to like not say anything or show expression just not to freak out my patient. But you feel a knee, you're like, whoa, you got to be
You call the students over and you're like, come feel this knee. It's so loose. They're freaking out.
It's so loose.
Yeah.
It's so loose. Freak your patient out completely.
Yeah.
All right. Principle or key number 4, strengthen the rotator cuff and the scapular muscles, right? And you'll see this in pretty much all of the studies, including this meta-analysis. There's one thing that's continuous across all of these studies. They're doing some sort of strengthening and usually focusing on the rotator cuff and the scapular muscles. And some of the other studies did focus on the core, the hips a little bit, but for the most part, focusing on the rotator cuff and the scapular muscles is most prominent in all of these studies, right? And we're not going to go over all of the different exercises that I like to use to try to strengthen these folks. I will be putting out some future videos on the Fitness Pain Free channel. So definitely stay tuned for that on the exercise I like to use for those folks. But I just want to give you a general idea of how you would progress through. So usually start with easier exercises and we progress to harder exercises. So it might mean that you're starting with exercises below the shoulder. So it might be things like sideline external rotation for the rotator cuff and scapular muscles. And over the course of time, we start to progress above the shoulder because eventually we need to throw a baseball, right? So maybe we're doing 90-90 external rotation because that's going to be way more specific for the athlete and really important a position for that person to gain strength, right? But if we start with that standing 90-90, it might be a little too provocative. Again, if your athlete can handle it from the get-go and it feels great, I'd start with the harder exercise, but do keep in mind that you might have to start with easier stuff because they are so irritated, right? Maybe you start with a prone extension or dumbbell A, whatever you want to call that. And over the course of time, you go to a dumbbell Y because a Y is going to be a much better exercise from the standpoint of specificity, right? I'm hucking a baseball as hard as I can. When I release that baseball, I have to be able to control my arm back down, right, below my shoulder. The Y kind of simulates that a little bit. Prone extension doesn't, right? The prone extension feels really good early stages of rehab. Dumbbell Y usually doesn't. So you kind of meet the athlete where they are, give them the hardest thing they can tolerate well, but we're probably starting with easier exercises like the prone extension, progress into Y. Another no-brainer but we can start with light loads and progress to heavier loads over the course of time. And this could be with all of your basic exercises like sideline external rotation, T's, Y's, so on and so forth. But it's probably going to be for things like pressing exercise and rowing exercise in the gym. Probably going to have to start a little bit lighter and progress to heavier loads over the course of time. We want to really have a strong and robust shoulder joint. So we do that by getting the shoulder stronger. And we know from a strength conditioning perspective, we have to increase the loads to build strength, right? So we can't get stuck in this, easy, tiny dumbbell or like band warm up stage, which a lot of patients do. They essentially start feeling a bit better. They still do their exercises, right? They'll use bands, like J bands are super popular in the baseball world. Like I still do my band work, but the bands are super light, super easy. We're not really overloading the shoulder to get more robust, right? So we need to make sure that we kind of extend beyond that, get the shoulder stronger. And we also start with slower speeds and we progress to faster speeds. And I think this is particularly important when you're thinking about baseball players or overhead athletes because their sport revolves around speed, right? You're trying to huck a baseball as fast as you possibly can. I don't care how many cable or dumbbell exercises you do, that's not going to be as specific to the shoulder compared to, let's say, a plyometric exercise. So I think eventually, especially for this population, you need to start working on some impact activities. You need to start working on some throwing exercises. So maybe you start with something like a 90-90 internal rotation, and then you progress that to wall dribbles with a medicine ball against the wall, right? And then if you're working with, let's say, an Olympic weightlifter or someone in the gym, you might start with something like a dumbbell strict press and then progress to faster barbell overhead movements like a barbell push jerk, right? So just following those principles of slow speeds to fast speeds. What do you think, Kevin? Am I wrong? Am I right?
You're right. You're right.
Yeah.
I think that it's important to remember, like we're talking about keys to slap rehab, but I think the way that we get back to sport depends a lot on the sport they're trying to get back to, and a little bit independent of the exact pathology with a slap tear, right? So we want to obviously take into consideration, like you said early on, modify the things that aren't feeling good, but then we have to really tailor it to the person who we're working with. And there's not one rehab approach for rehabbing a slap tear. There's a rehab approach for returning a baseball player back to pitching. So I think that's important to keep in mind is you're not treating the pathology, you're treating the athlete. So whether that's an Olympic weightlifter or an overhead thrower, we have to take into consideration what the demands of the sport are and really design our rehab program to optimize that.
Yeah, very true. True words were never spoken before, Kevin. Key number 5, we got to get specific. And we already talked about this a little bit, right? But eventually we get through the stage where the shoulder was really sore in a bunch of different range of motions. Eventually it stops kind of hurting through your daily activities. You restored the range of motion. And now we're starting to get back to game situations and playing a little bit, right? So what that means is that we have to start getting more specific in our exercise selection, just because we know that the athlete has to tolerate something very specific, like throwing a baseball as fast as they can off a mound, right? Like I said previously, 5 out of 5 of these studies use some form of strengthening, okay? We already mentioned this, but for a baseball pitcher, I probably need to be working on 90-90 external rotation, internal rotation. I'm probably working on some diagonal patterns like PNF. The reason being is that you throw a baseball, you have to decelerate it. You need to decelerate your arm down, back to your side, across your body. Those diagonal patterns need to be strengthened. Working on T's, working on Y's. All the muscles that decelerate the arm are going to be very, very important. The muscles that also accelerate the ball are going to be very important too. So we can't forget the lats, the internal rotators, all that stuff is going to be very important, right? The other thing that we use a lot at Champion, and they use in some of these studies, not all of them, was going to be some sort of single arm plyometric work or some sort of activities that are considered functional, right? Got to be able to throw a baseball. One kind of intermediate that we use a lot at Champion to see if folks are ready to start throwing is, are they tolerating single arm plyometric work well, right? So if they get strong, we rebuild their range of motion, we rebuild their strength, those numbers looking good. We'll start with some plyometrics. So we do double arm first, follow it with single arm. If things are going really well, we can start that interval throwing program, right? So we're just advancing them along that spectrum. So a little bit more information of that criteria-based return to sport. We're kind of checking all the boxes as we go to make sure the athlete returns as safe as possible. So this was only one of 5 studies, but they utilized some core and hip strengthening. Now, I do think this is really important. And we're kind of like, we're very lucky at Champion PT and Performance, where both Kevin and I work, just because we work with strength conditioning coaches and we're in a full gym. And it's a sports performance gym too. It's not like it's connected to a Planet Fitness. We got everything, right? So not only do we get our athletes out in the gym and try to train their entire body, we're often trying to get them into the strength and conditioning system, working with our coaches there. So they're working their entire body, right? And we're also trying to get them stronger with all the musculature that's going to improve their performance as well. And I think it's a really nice system because the rehab fits with the strength conditioning and improves our outcomes overall. Plus, most athletes are just trying to get back to playing their sport and they want to get better at their sport. So the sports performance stuff is really, really helpful, right? And in 2 of the 5 studies, they actually did work a little bit on throwing mechanics, which I thought was interesting. We do have research about throwing mechanics placing more or less stress on certain parts of the body. There's a decent amount on the elbow. I am not an expert. We're very lucky at Champion too that we have throwing coaches as well, right? So if I have questions, I just send them over, to someone else so they can actually look at the throwing mechanics. Anything to add to that, Kevin?
Yeah, I think I treat a lot of baseball players, but my knowledge on pitching mechanics are very poor, right? So having a pitching coach in the building has been amazing. I think one thing that I was thinking about that you said earlier was, if there's a rock in your shoe and you take Tylenol or NSAIDs and you feel better, but the rock is still there. I think a lot of especially the younger guys that I see, the younger baseball players who aren't as sound mechanically, we might find the rock as their shoulder pain and be able to work on that. But if this kid is just throwing with his arm and he's getting bigger and stronger and he doesn't know how to use his body, I think hip and core strengthening would be helpful. And I think having a good assessment with a pitching coach would be really helpful to learn how to sequence a little bit better and improve their mechanics. So maybe they're reducing stress on their shoulder or their elbow. So, that's definitely like a higher level piece of the rehab, and you might not be the best person for it. But making connections, if you do want to see more overhead athletes, I think having good strength coaches that you can refer people to, or having a good pitching coach. And I think these days online, you can find people more and more. So I think that's going to be important for people too, because you can get their shoulder better, but this issue might come back if their mechanics are crappy and they're just throwing with their arm. So definitely something I would like to see more of those studies include. And I think it would be really helpful for the patient.
Yeah. I just want to second what you said. I think when I started as a physical therapist, if I didn't know every aspect of care from rehab to high level performance, I felt like a failure, right? I'm not sure if other PTs maybe feel that or new grads, but one of the things I've realized over the course of time is that you don't have to know everything. It certainly helps to have an idea, help folks out. I think the other piece is that there's always going to be people that are better than you are in a specific niche, right? So like I am doing a disservice even for my like elite Olympic weightlifters. Like I've done a lot of research about the mechanics of weightlifting and weight training. I've done it for years myself, and I've coached a lot of other folks, coached some high level guys, but I still think I'm doing a disservice to an athlete if I'm trying to coach them when I know I have a better coach, right, in my network, right, that does this every single day and they're extremely good and they do that for a living, right? It's kind of stupid for me to think like I'm going to be the expert. I'm not. I'm a physical therapist and I do physical therapy all day. I'm good at physical therapy. If the Olympic weightlifting coach was trying to do physical therapy, I'd be like, all right, well, that's a little odd. And maybe they're doing a great job. I have no idea. But I think that just finding really good people and reaching out and referring is really helpful. It helps to improve your outcomes and it takes a little burden off you, right? You don't have to know everything about pitching mechanics or whatever it is. And in fact, you're probably going to do a disservice if you're trying to do that because there might be someone that's better than you. So, key number 6, and the last key is returning to sport, right? And we already talked a little bit about this. We have some criteria that we want to see kind of on each stage all the way back to return to sport, right? And we'll talk about a pitcher just because I think that's been the theme, but this is going to be Very similar for, let's say, tennis or volleyball or other overhead sports, right? So first and foremost, looking at full pain-free range of motion. We want to see that symmetrical total arc side to side. More or less, we want to see that flexion the same side to side, just because an overhead athlete, obviously you're using those ranges of motion. We want to make sure they have a completion of a graduated rehab protocol. This one's very nebulous, right? Like, what the hell does that mean? Did they finish rehab? Did they not finish rehab? What does rehab consist of? I think what it probably means to me is that you start with some easier exercises. You make sure they're tolerating that well. You go to harder exercises the same way we described. We make sure their range of motion is returning. It's symmetrical. It's not painful. Eventually, we progress to some plyometrics. The plyometrics going really well. Then we do an interval throwing program, right? And if they pass all that stuff, they're doing great. Then we can return them back to sport, right? Well, let's stop there. What do you think about that, Kevin, before we move on? Because I think there's a lot to that.
Yeah, I think it's starting with the strength and just understanding what the demands of throwing require. So that 2/3 ratio of external rotation to internal rotation is something we look at. In the throwing motion, we think of the internal rotators, specifically like looking at your shoulder, are going to be the lat and the pec, teres major. They're going to play an important role in generating ball speed. So those are going to be stronger, bigger muscles. But to counteract those, your little external rotators on the back of the shoulder are decelerating your arm at ball release. So if you're throwing really hard and you're not doing a great job decelerating, that stress is going somewhere, and it's probably going, in different parts of your shoulder and maybe keeping you a little irritated. So we want to see those strength numbers there. We also look for external rotation to be about 15 to 20% of body weight. And the reason for that is that it's just a little more specific to the individual you're working with. So if you have a 200-pound pitcher, we expect those external rotation numbers to be a lot stronger than someone who's a lot younger. So we definitely look for that. Once someone's hitting that criteria, we start a throwing program. And I think that said 1 out of 5 studies had included that. So that's definitely something that we want to see more of as well. My big thing that I like to do is run. So I always think of this in terms of running. But if you go through a rehab program and then you just go back to racing 5Ks or 10Ks without any type of return to run, it seems crazy, right? And I think we can all appreciate that if we treat people returning from ACL. We're not just going to send them out for, a 3-mile run right away. We have to get those tissues ready to run. And that's what I tell our baseball players when they start pitching. I think Mike Reinold has done a great job writing those programs that we use. The athlete might think it seems a little slow to start, but I try to tell them that we're not working on improving your velocity right now. This isn't a time to work on improving your slider or changeup. That comes later. Right now, we're just getting the shoulder and the elbow used to throwing again. We're kind of putting these ligaments on stress that haven't seen the stress for a while. And it's a very slow, gradual progression. So it's such an important piece of the process. I think earlier we talked about like risk reward for the patient. Is there some patients that could skip this phase and just get back to playing? I mean, maybe, but why are you going to risk all that hard work you just did? Just, you want to slowly build back up, especially if you're pitching, then you got to get off the mound. So you go through your long toss program and then you go through a mound progression. So it's a long process, but it's to condition your arm to get used to throwing again after that extended time off.
Yeah, when I read that, it blew my mind a little bit, because in my mind, like, that interval throwing program is like 50% of your rehab, It's like if you just had a patient that had a slap tear, if you just like gave him 4 weeks of nothing and then an interval throwing program, I'm curious how they would do, right? Because you unload them, and then the interval throwing program is such an important part, right? It's like when someone has Achilles tendon pain, we'll probably modify the way they run, but their running is probably rehabbing them, right? So just the fact that like around 80% of these players returned, and then in most of these studies there was no interval throwing program, I couldn't even imagine that, right? So I don't know. In my mind, it's like, well, maybe you can be a little bit debonair and skip some of these steps. I wouldn't, right? It's like I can't, like, we very rarely don't give someone some sort of interval throwing program to return or a return to run program. We may modify that interval throwing program a lot, right, based on the individual. So based on the injury, and this could be a whole nother talk, and maybe we'll get Mike Ryan or someone on here because he is a true expert with this stuff. But your interval throwing program is going to change a lot based on the athlete and the circumstances, right? How fast you need to return by. What is the injury that you're dealing with? What position you're trying to get back to? Because if you're first base, that's a lot different than a pitcher. So you basically need like a return to throw program, and then you have like a mound progression too, right? So there's a lot to that. But yeah, only 1 out of 5 of those studies actually included one. The other thing, and you already kind of noted on this a little bit, is the idea of balance in the shoulder. And I think this is something that the physical therapy community has taken and completely ran with every single type of athlete. And in my mind, it's super specific to throwers and overhead sports like tennis. So essentially, you have one set of muscles that accelerates the ball or the racket, and another set of muscles that decelerates the ball or your arm, right? So essentially, if your acceleration muscles are stronger than your your deceleration muscles, you can get an injury. And that's the whole theory. Let's make sure that your deceleration muscles are strong enough, right? A little pet peeve of mine is that, we'll try to take this data and apply it to like a power lifter, right? And if a power lifter is bench pressing, their acceleration muscles are nearly identical to their deceleration muscles, right? So we might be working the back of the shoulder, but for different reasons. So that this idea of balance, I think, is mostly for a pitcher. However, it is really important. So I think that that is very valid. Going back to our slides, the other thing that you can utilize, so those numbers that Kevin just talked about are great. So we're looking for that ER to IR ratio somewhere between 2/3 to 3/4. It's pretty amazing what you'll see sometimes in athletes. We've seen guys that have like 70 to 80 internal rotation and like 20 to 30 pounds of force in external rotation. Like you'll see that quite a bit. And like these folks will get weaker into external rotation oftentimes over the course of a season. So if you're halfway through the season, shoulder's getting a little beat up, your external rotation strength has gone in the toilet, that's a sign that maybe that shoulder is taking a beating. Maybe they have to back off a little bit, right? Especially if it's starting to get painful. So you can also use normative data in order to figure out how much external rotation or internal rotation your athletes need. So I'll leave a link in the show notes for professional baseball players because there is some data, and it's data for different position players too. So essentially non-pitchers versus pitchers. But you also see normative data in regular people, so general population. Now keep in mind, that's probably not as important as with a baseball player, but you'll have normative data for average people. There's also some normative data for swimmers and some other sports too. So if you want to do your due diligence and try to get their strength up to a certain amount, you can compare that against peers, right? And that's probably the best way to do it. Just because for my weightlifters, we don't have normative data. So I'm a little bitter, you know what I mean? It's like, what's the internal rotation, external rotation strength of a power lifter? Like we don't have that, and I didn't do a PubMed search prior to this. Like there might actually be that data. I just don't know about it. If someone knows about that, send me a comment. But yeah, you want to make sure that you look up and see if there is normative data, and that's maybe your gold standard of where you want to get your patients over the course of time, right? And the last piece is just that the return to sport takes time for this injury, around 5 months or more on average, right? One of the things I will say is that you might find that those weightlifters get back a little faster, potentially, maybe, right? Maybe the pitchers, you have to slow things down. We know that they don't really get back quite as fast, they don't have the best success compared to other athletes. Maybe you want to slow things down a little bit for those folks, but that's just an anecdote. I'm not sure if that's actually true. So any thoughts on that, Kevin?
No, I think that was a good summary. I think it does take time. That's the thing that we want to talk to these folks about. And I would imagine it takes time to get back to the prior level of performance, which is what most of the people we see want to get back to. They don't want to just get back into games. They want to get back into games throwing as well as they used to, or, better than before, which sometimes can happen with a little downtime and good rehab. And, sometimes people feel better than they've ever felt. So I think it takes time, and just, educating the patient to trust the process and work on these impairments. And you might not need a slap surgery, maybe we can avoid it and get back on the mound successfully.
All right, so now you know a ton about the treatment of slap tears. You still have to make sure you're actually working with an athlete with a slap tear. Well, I have a video for you. We're going to take that. Oops, not over here. It's over here. It's over top of Kevin's head right there. Click on that. It's a video about how to diagnose slap tears. So when you click on that, I'll see you in that video. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.